Hey guys, this is Pete Croft. I'm an ER doctor up at Maine Medical Center and currently the medical director at North Yarmouth Fire and Rescue. I wanted to make a short presentation today on spinal immobilization, in particular, and in regards to the new protocol update coming out in just a few weeks here statewide. I was asked to put this together by Chief Payson and was planning on doing it a few weeks ago, but we had the Memorial Day flag placement that night, so had to be postponed. And in regards to time and not being able to fit it in another night at the meetings, I thought this was a good alternative. So let's get started. So first off, being in Maine, living in Maine, we're sort of at the heart of it all in terms of evidence and the studies that have been done. Former EMS director John Burton did a study years ago that included 32,000 patients. And the crux of this is that only one clinically significant spinal fracture was missed. This showed that EMS providers across the board can safely implement a protocol for suspected spinal injuries. It's completely within your skill set and ability to do this and do it effectively. The one other interesting facet of the study was that the one spinal fracture that was missed was actually in a quite elderly male that had a fall a week previously and had been having pain since then. So it wasn't your typical trauma call out. So let's look at the evolution of the backboard, since this is what crux of this talk is revolving around. So, this is obviously not anywhere near what we're using today, but this was a depiction back in the medieval ages, showing straightening out the spine in a scoliosis patient. Today, and in more modern times, this is more what we're apt to seeing. This was one of the first backboards. It's called a Henley board. It's made of birch plywood. It was mostly down in Maryland where this started, in the mid-Atlantic states. Also, long qualities of these boards as well were developed. Also, metal types and prototypes. In the 80s, we moved on to more plastic representations. And interestingly enough, the main reason for this wasn't necessarily cost or durability, but more along the lines of the epidemic of HIV and AIDS. And the blood exposure to these backboards was found to be quite risky, and having a plastic backboard made it much more easily cleaned and after each use. So moved into plastic backboards, and these folding backboards became popular, as well as newer models that contour to the body and more represent a body surface area, as well as more padding was involved. The Tomcat backboard came about as well more recently, as well as the Combi Carrier by Hartwell. This Combi Carrier also had this additional head equipment placed. And then even more recently, the modern vacuum mattress. This is used commonly in Europe, except in rapid extrications. So where did the backboard start? In 1968, this trauma surgeon, J.D. Farrington, made a comment that was widely known at that time that had stated that survey of accident victims, firm immobilization, and inline traction are the basic principles of extrication. This statement carried through the years and became a foundational piece of EMS and the use of backboards. In 1984, the EMT standard curriculum lesson plan had very broad indications for full spinal immobilization. Taking that on and reading this and taking it forward made people use backboards extremely broadly and commonly, and not with any exact specific indication. This led to widespread use to almost where we see it today, where it's used really, really commonly and perhaps incorrectly, and likely leads to the institution of this new protocol that we're rolling out in July. Excuse me. None of this protocol in July will be changing how we evaluate spinal injuries. Is that study at the beginning of the slideshow showed that you all are exceptional at doing that. So we don't have to change how we do that. Just have to update how we immobilize the spine, and ultimately probably use backboards much less than we need to at this current time. We'll go over why that is in a second. So let's talk about some cases in particular and types of trauma. So first is penetrating trauma. Interestingly, patients with penetrating trauma to the head, neck, or torso, such as the patient in that previous picture, without evidence of spinal injury such as obvious paralysis or focal neurodeficit, should not be immobilized on a backboard. This is a direct counter use to what we're doing now. Most of these patients do end up coming to the ED on full immobilization. It has been shown that these patients, if they are alert and if they're oriented, if they're not showing any focal deficit or an obvious paralysis, that they do not need to be immobilized on a backboard for transport. That is to say, they should be placed in a rigid cervical collar with care, in particular if this trauma is to the head or the neck, and this patient should be secured to the EMS stretcher. This was a life support executive committee back in 2011, made of numerous providers from different types of fields, EMS, emergency medicine, trauma surgery. Their consortium decided and came up with these tenets that, number one, no data to support routine spinal immobilization with penetrating trauma to the neck or the torso. Likewise, there's no data to support routine spinal immobilization with isolated penetrating trauma to the cranium. Number three, spine immobilization should never be done at the expense of accurate physical exam or identification and correction of life-threatening conditions. This is very important as well, placing your ABCs at a paramount here. And lastly, spinal immobilization may be performed after penetrating trauma when a focal neuro deficit is noted. Interestingly, there's not a lot of evidence that spinal immobilization even benefit these cases. The interesting thing about penetrating trauma is it has to do with this three-column theory of the spine. Most penetrating trauma, the body and the spine are not in motion when the damage is incurred. This is in opposition to blunt trauma, where the body and the spine are definitely in motion, such as in car accidents and falls. Penetrating trauma, the missile or the explosive produces a concussive force that doesn't often affect the spine stability, because your body and your cranium and your spine are not moving at the time of impact, which has less degradation on the spine itself, if that makes any sense. So there's definite harm shown if we place patients on backboards with penetrating trauma. Backboards, as well as cervical collars, do increase intracranial pressure. They impede respiratory function, which I'm sure you all have seen firsthand quite often. It also limits the opening of the mouth. This is something that we highlight to our residents whenever we have to intubate patients with a cervical collar, in that this needs to be removed immediately and someone needs to hold immobilization and C-spine stability during this procedure. But it certainly impedes that respiratory function and hinders the ability to intubate a patient. Also, it has been shown that demonstrated that pre-hospital spinal immobilization is correlated with a higher mortality in patients with penetrating trauma. And the authors of this particular study, and there are so many out there, recommend against its use in this population. So take home for penetrating trauma, the need for full spinal immobilization is exceedingly rare. Just a few numbers to throw at you. I won't bore you with these, but 34,000 patients with blunt trauma, 2.5% essentially had C-spine injuries. The majority were stable spine injuries, meaning that they typically didn't have to go to surgery. They were managed conservatively. 30% of the total injuries were considered insignificant. So while C-spine injuries are worrisome and they definitely need to be managed and handled accordingly, 34,000, only 2.4% had these injuries. Most were stable, and 30% of the injuries were considered insignificant. Again, 57,000 assault and trauma patients. C-spine fractures from blunt trauma occurred at a rate of 0.4%. So that math, let's see, so that's 5,500 is 1%, so less than half of that. So looking at about 2,000 of these patients, no, that would be I'm sorry, so 500, so 200 of these patients would be having a C-spine fracture. In gunshot wounds, this number was 1.35%, so actually a bit higher. And in stab wounds, it was significantly less. And this is just one study of 50,000 patients, essentially. So let's talk about self-extrication, because this is a direct point of emphasis in this protocol as well. So first of all, who can self-extricate? Just give you a second to think about what type of patients are appropriate for self-extrication when you arrive to a scene. So essentially, it's the same patients that are appropriate for sign-off, right? So it's the patients that are calm, cooperative, sober, alert. They don't have any barriers to communication. They can reliably hold their spine still while moving from the vehicle. And they have no significant injuries that you see overtly, such as lower extremity injuries that will hinder their ability to self-extricate. Anyone who meets a criteria such as a GCS of 15, no spinal tenderness, no neuro complaints or exam findings, no distracting injury like we mentioned above, and no intoxication do not necessarily require immobilization with a backboard. Okay, so these points just go on to just emphasize what you're already doing. It just gives you a little bit more leeway in terms of utilizing a backboard as well as utilizing the ability to let patients self-extricate, and it allows you to defend yourself in these cases. So allow your patients to ambulate with or without assistance to the cot or stretcher with a cervical collar in place. This is only, of course, when they have a positive spinal assessment on the scene. There's little to no need for a standing takedown in any of these cases. If your patient cannot ambulate to the stretcher, then just use a backboard, take them to the cot, and once there, remove the backboard. If the patient requires stabilization, you can always use a head block as well. The patient can be secured to the cot with seatbelts. So this is another fairly big paradigm shift. An emphasis of these protocols is to allow patients to come off the backboard if you're using it just to transport them from the scene of the accident or trauma to the cot or stretcher itself. So where is the evidence, you may ask? High-speed infrared motion analysis cameras and sensors. It's a handful to say. To detect motion of the cervical spine during 4 different extrication techniques. This was a study done in 2013, and it was published in the Journal of Emergency Medicine. So 4 different extrication techniques were looked at. So unassisted and unprotected. So patients got up, walked on their own to the ambulance. Unassisted and protected with a collar. Assisted and protected with a collar. And assisted and protected with a collar and an extrication device. In this case, they used the Kendrick extrication device. Essentially what they found was that conventional extrication techniques results in more cervical spinal motion than placing a rigid collar and allowing self-extrication. So let that sink in for a bit. Essentially, conventional techniques will create more motion than simply placing a rigid collar and allowing self-extrication to take place comfortably. Very interesting studies and a good subset of patients in these studies too. So let's look, I mentioned before, we're going to look just at backboards and potentially the harm that they can do. So backboards do cause pain. They do cause agitation. They limit mouth opening, making airway damage management difficult. This is especially in conjunction with cervical collars. They tend to restrict respiration. They delay transport. They can cause pressure sores. And they also, interestingly, and I found this to be especially truthful, is that they can increase imaging rates. And that's a bias on the providers in the ER, seeing patients come in on a backboard as opposed to not on a backboard. That initial visual image will lead us to do more imaging. And these comments have all been borne out in studies, and there has been, as I mentioned before, quite many of these. Up to 17% reduction in respiratory function. This is a greater effects at the extremes of age, so younger and older patients, which tend to be very commonly involved in these accidents. Low back pain and cervical pain persisted in healthy adults for 24 hours after spending 1 hour on the board. I'm sure you guys have seen patients complain of the pain on the back from being on a board just for transport from North Yarmouth to Maine Medical. The other thing this does is tend to muddy up the waters when they do arrive to the ED and they get a spinal or back assessment in the ED. Often find them to be tender in areas where they may not have been tender if they were not on a backboard, if that makes any sense. This one study looked at tissue hypoxia and found that in the sacral area, it occurs after just 30 minutes in healthy adults placed on rigid, unpadded backboards. They do not improve patient outcomes. They don't make your life easy. And likewise, they don't worsen an existing spinal injury. So you're not going to worsen a spinal injury by placing someone in the backboard. Furthermore, there's no role for backboards with inter-facility transport in patients with known spinal injuries. These patients should be secured to the cot as if they were being secured to the backboard, so with your seat belts. This allows the natural curvature of the spine to be maintained. I apologize for my cold today. So if the backboards are so terrible, when should we use backboards? This is important. So, this talk and this protocol is definitely de-emphasizing the broad use of backboards in our EMS system in Maine. But there are still roles for backboards. And let's look at a couple of these. So when self-extrication isn't possible, remember, these patients can still be transitioned to the stretcher when you get them out of their vehicle or their place of injury. But when it's impossible, this backboard may help you do that. Patients who cannot protect their airway and may need to be turned on the side. This is super common. Patients that are intoxicated very much or have significant head injuries with a low GCS that may lead to emesis and vomiting. The backboard will help you move them on their side. So again, multi-system trauma, multiple long bone fractures. This goes along with distracting injuries, and which the backboard can help in an element of splinting these injuries. Unresponsive, agitated patients, a backboard may still play a role. And when removal would delay transport, this is really important, right? So if your patient's unstable or if you're really worried about them and you're going to take 5-10 minutes to get them off the backboard, these are patients, just leave them on the backboard and bring them to the ED. So there is a time and a place for backboards, of course, specifically in the cases we mentioned above. That said, there is a growing consensus, and one that has made it to the point where we're changing our protocols here in Maine, that the repeated use of backboards with all trauma patients is tantamount to negligence. And that's because of the reasons we showed before, that it just does not improve outcomes. It causes adverse effects, and it definitely delays patient care, leads to more imaging, causes pain and agitation, and so forth. It took a long time to finally get to this point, but I think it's a good thing for EMS, it's a good thing for patients, and it's a good thing for our medical system that we're moving this way. So how do we master it? How do you guys master it? Essentially, learn to defend your rationale for spinal immobilization. We talked about the reasons where there still exists rationale for using it. So when you document and you make your run sheets, simply discuss the rationale behind your use of backboards. And you guys, as we mentioned right at the beginning, are quite good at this. So no doubt that you'll perfect this strategy and hopefully will lead to patients being more comfortable and better outcomes in the hospital. So thanks so much for your time. Please let me know if you have any questions. Send me an email and let me know if there's any other topics we can discuss coming up in the future. All right.